Epilepsy. She earned her medical degree from Wayne State University School of Medicine in 2006 and completed her internship at the University of Michigan Hospitals and a residency in neurology at the University of Michigan Hospitals in Ann Arbor, Michigan. Dr. Gupta then completed a fellowship in clinical neurophysiology, epilepsy at the Warren Alpert Medical School of Brown University. Dr. Preeti Gupta is deeply passionate about both medical and patient education, believing that informed patients are empowered patients. This dedication to education ensures that patients fully understand their condition and treatment options, leading to better health outcomes and greater satisfaction. This commitment to education fosters a collaborative and supportive environment, ultimately enhancing the quality of care provided. She is also an assistant professor in medical sciences at the Warren Alpert Medical School, Office of Medical Education. She is a recipient of the Dean's Excellence in Teaching Award. Currently, she is the two-year course leader for doctoring and course director for the Clinical Skills Clerkship. She is actively teaching students in their second year of medical school. Previously, Dr. Gupta co-directed the Clinical Neuroscience Clerkship at the Wayne Alpert Medical School of Brown University. And we are so happy that she is with us tonight. I do want to remind our families tonight that all of our doctors that come to us on Wednesday on our webinar series are volunteering their time with us. So we're so appreciative of them volunteering our time. Little house cleaning tip. If you do have questions, if you can please put them in the chat, that would be great. During some parts of the presentation, Dr. Gupta will either stop and Amy and I will go ahead and read the questions to Dr. Gupta. If it is a question that needs more explanation, then we will ask you to unmute yourself and be able to add a little bit more information. So that being said, I am happy to pass the mic to Dr. Gupta. Welcome.
Thank you so much to the Epilepsy Foundation and to Christine and Amy for inviting me to speak with all of you today. It is truly an honor, and I'm so excited to be here. Like Christine said, this is my first webinar. And I did the Epilepsy Foundation walk a few months ago, so it's very exciting. So I'm a neurologist in Rhode Island, and I specialize in epilepsy. And today I'll be speaking with all of you about a topic that is very near and dear to my heart, epilepsy in women and women's health. And we're going to really talk about best practices for seizure control from preconception all the way to menopause. And this is a huge topic, so we're not going to cover everything, but my goal is really to highlight the important aspects of this, dive into best practices, and really make it as interactive as possible. So ask any questions, and Christine and Amy, feel free to just jump in and let me know if there's questions, and I can certainly pause as we're going through this. So I have no disclosures. And I just wanted to start out that for the purpose of today's talk, when we talk about our effective population, women with epilepsy, this phrasing really doesn't recognize the importance of biological sex and sociocultural gender. And so in the new guidelines that were recently published by the American Academy of Neurology, and it really brought together guidelines from neurology, epilepsy, and also our OBGYN colleagues to use gender neutral language. People with epilepsy have childbearing potential. So you'll see both used interchanged in this presentation. All right, so for our objectives today, we're going to talk about the hormonal changes of seizures, demonstrate safe and effective care for pregnant women with epilepsy. We'll talk about the impact of anti-seizure medications on reproductive health, and then talk about the importance of like that multidisciplinary approach to caring for women. It's not just one doctor that can do it, and so it really involves a team. So let's start first with some history. And this is interesting, I think, to look back. And when we look back, the first anti-seizure medication was first discovered back in the 1950s. And it was around the 1960s that there was this first report of malformations associated with anti-seizure medications. And then in the 1980s, so not too long ago, there was the discovery that specific medications cause specific congenital malformations during pregnancy. And then it was around this time in the 1980s that we started to learn about behavioral manifestations of our anti-seizure medications. So behavioral manifestations of in utero exposure to these medications. And then it was really in the 2000s that there was human studies that was done looking at the congenital malformations, both from a behavioral and a structural standpoint. So if you look at all this, it's fairly recent. And so today we're going to talk about some of the things that have been discovered. So when we talk about the introduction to women's issues in epilepsy, it's important to note that epilepsy affects both men and women equally, but women need this tailored approach to care because they go through many different stages: adolescence, pregnancy, menopause. And what's also unique for women is that there is this hormonal contribution to seizures. And we're going to go into that in more detail. And so it's really important to understand how those hormonal influences affect medications and how we decide to treat and make changes over time as well. And then there's challenges in different stages of life, and those challenges can really impact the management of epilepsy. So epilepsy is one of the most chronic neurological conditions. And I pulled this 1 out of 26 people will develop epilepsy during their lifetime from the Epilepsy Foundation website. And so 1 in 26, that is a good number. And so if you think of a room, or even, that's 1 in 20, 25 people almost. It affects 70 million people worldwide, and 15 million are women with epilepsy of childbearing potential. So what is epilepsy? Epilepsy is having this increased tendency towards seizures, either having 2 or more seizures, or having 1 seizure and having an increased risk towards seizures. It's important to know that all seizures are not convulsive. And, I think in this group, we probably know that, but I think sometimes to our general public, it can be a misconception. So not all seizures present with shaking. And different medications are used to treat seizures that are coming from one area of the brain versus the entire part of the brain. So figuring that out is really important, to figure out where in the brain are the seizures actually coming from. And so with epilepsy, we're really not talking about seizures that are unprovoked or related to seizures that happen from low blood sugar, or withdrawal seizures, or in this case, eclamptic seizures that also can happen during pregnancy. So when we talk about hormonal influences in epilepsy, the key hormones, estrogen and progesterone, can really impact seizure activity. And what people don't really know is that the brain has receptors for estrogen and progesterone. And it's these fluctuating cycles of estrogen and progesterone through a woman's life that can really influence seizure tendency. So estrogen is known for its proconvulsant effect, for its increasing seizure likelihood. And progesterone is known for its anticonvulsant effect, so reducing seizure threshold or reducing seizure frequency. And it's really this impact of the role of how these change over time that can influence seizures. So one real world example of this is catamenial epilepsy. And catamenial epilepsy is epilepsy that fluctuates based on menstrual cycles. So approximately 1/3 of women diagnosed with epilepsy experience catamenial epilepsy. And with catamenial epilepsy, seizures can occur during different stages of the menstrual cycle. So some can occur during the ovulation stage, or some can occur during the pre-stage, right before women are about to get their menstrual cycle, and some can occur during the menstrual cycle. And we tailor treatment based on what phase of the menstrual cycle the seizures are happening at. And so this is a really busy diagram that basically shows you that different stages can have a different effect on hormones. So if you look at the diagram, you can see here that during the stage of ovulation and before, let me see here, during the stage before ovulation, there's a higher, there's like this higher tendency towards estrogen. And that's when you see that there can be an increased level of seizures. And it can really vary from women to women, women that are affected with catamenial epilepsy. And there's been lots of studies that have been done to look at what are some treatment options for catamenial epilepsy. One study looked at progesterone. If we give women progesterone, will that help? Because we know that progesterone is an anticonvulsant. And they found that it really didn't make that much of a difference with that study. One study looked at clobazam, which is an anti-seizure medication, and clobazam can cause some side effects of fatigue, and so it really wasn't found to be that favorable. And another study looked at a medication that it's actually used to treat migraines, acetazolamide, and found that that really didn't help as well. And there was some thought that epilepsy and migraine can be on a single spectrum. And so if we used a medication to treat migraines, could that potentially help with this? And so really what we do in practice is to really help with our patients to say, okay, let's document it. Keep a diary. When are you having seizures in your menstrual cycle? And can we really target that period and maybe potentially increase the medications during that point? So that's usually the most common thing that's done. Of course, balancing side effects and making sure that we're not, there's no side effects when we make these slight increases during portions of that. And that's only for catamenial epilepsy. And then when we think about epilepsy treatment in transgender women, these are women that might experience stigma or reluctance to really discuss gender identity with their healthcare provider. And it's really important because drug interactions from gender-affirming medications can also cause increased seizures. So being open and having this discussion is really important. Transgender medicine is such an emerging topic, and there's so much research that is still being done in this field to really create like an individualized approach to care. So next, we're going to talk about sexual dysfunction and fertility concerns. And this is interesting work that's been done. We know that sexual dysfunction among women with epilepsy have been linked to multiple factors, some due to poorly controlled seizures or disabling seizures. Sometimes sexual dysfunction, even in women without epilepsy, can be due to comorbid mood disorders, and medications themselves can have so much effect on sexual dysfunction and decreased libido. And there are some medications that we find this more compared to others. And when we think about the effect on fertility, right, the question is always, will this medication, women have asked me so many times, will this medication affect my chances of becoming pregnant, of fertility in general? And in 2018, there was a study that was done that looked at, they recruited women with epilepsy and women without epilepsy from the ages of 18 to 40, and that average age was about 30 to 32. And this study really did not identify any difference between time to pregnancy, so 6 months for women with epilepsy and 9 months for women without epilepsy. They didn't really notice any difference in sexual activity or ovulatory rates or even live birth rates. So I think this is really encouraging data for women with epilepsy that don't really have any pre-existing conditions for infertility, that really the chances of conceiving are exactly the same as women without epilepsy. So when we think about fertility treatments and seizure management, this again is that impact, thinking about the hormonal effect of these medications on seizure control. So there is for women that are struggling with fertility, assisted reproductive technologies do exist. And it's just really important to communicate with your doctor because a lot of those medications are estrogen, and so that can cause increased seizures. And so again, that's just some information in terms of the hormonal changes. And again, the success rates in fertility treatments are very similar for women with epilepsy and without epilepsy. That's definitely encouraging. So let's talk about a case, because I think it's always important to think about a case and put some context to what we're talking about. So this was a patient that I met. She was in her 20s. She was in her 20s, and her seizure started about a year ago. And she came to me, and the first seizure that she told me about started, it was a year ago. Her boyfriend found her on the floor, witnessed convulsions, tongue biting. The patient didn't recall any details. And when we talked about it, was there anything going on in your life at that time? Anything out of the ordinary? She talked about how she was working a lot. She had done a few back-to-back shifts, 2 12-hour shifts from 3 p.m. to 3 a.m. And then when we talked further about, okay, this one, maybe you didn't get any warning. Is there anything else that's been going on? She really shared about how she was having events of zoning out, and these butterfly sensation that starts in her abdomen with a metallic taste. So we started her on levetiracetam or Keppra, and then, or actually she was started on this before I met her, and then it was discontinued for some reason. She wasn't really sure if she needed it, and then I met her. And we had a great conversation. We talked about her history. We talked about these other events that were done. I did an EEG in the office. And during her EEG, she had a silent seizure. It was about 20 seconds, and it was coming from the temporal lobe, and I could see it on the EEG, and she had no clinical symptoms of that. And so that was really good information, because what it showed is that she was having some active seizures and needed to be on treatment. And so we talked about next steps, the risks of breakthrough seizures, in terms of things in her life that could cause breakthrough seizures, lack of sleep, alcohol, infection. And we really use this as an opportunity also to talk about contraception and family planning. And this is a nice time to pause, because I think that it's so important to plan ahead and talk about things before they actually come to the forefront. So a lot of pregnancies are unplanned. And I think that in the first moment, like when you're meeting somebody, it can feel kind of awkward to talk about this, but in all my patients, I talk about pregnancy and what are your plans for it? Is this something that you're thinking about? I've had so many patients that have called me first to say, I'm pregnant, and it's because I've opened up that door to talk about pregnancy. And so I always want to put patients with that information. So 50% of pregnancies are unintended, and about 65% of women with epilepsy have unintended pregnancies. And so, Christine, do you want me to pause at all for any questions, or keep going?
Yes, no, we do. Yeah, why don't we stop if you're okay with that?
Yeah.
There was a great question that came up in the chat, and the question was, does epilepsy affect pain and sex?
Oh, so that's a great question. Does epilepsy affect pain and sex? Is that the question?
In sex. So does it create pain while having sex?
Yeah, so I think, to be honest, I think that so much of what we're learning with epilepsy and the medications is that there are so many side effects that maybe we don't know of yet. And so we know that there are medications that can cause decreased libido. Pain with sex is not something typically that we think about with epilepsy or with seizures, and that there's a secondary cause that could also be going on. So not that we know of that epilepsy itself can cause that, but maybe the medications could be causing something like vaginal dryness that could cause pain with sex. Or if a woman's near menopause or perimenopause, and there is some vaginal dryness that's happening, that too can cause pain with sex or intercourse.
I have a question. I believe Casey. Casey, was your hand up? Oh, I believe she's. You're on mute, Casey.
Is that better?
Yes, that's perfect.
Thank you. I'm 63 and I'm postmenopausal. I've had some of the small strokes, um, in and so they've taken me off my hormone replacement therapy, off the estrogen, and I don't like this, or um, I don't. I really preferred being on the estrogen, along with the antidepressants and such. It really seemed to, I don't, soothe me or contain me. And is there anything you can think of to replace the estrogen? I haven't found anything in the antidepressant world um, that might help along in the hormonal world, that might help satisfy my epileptic hormonal needs, because I was born with epilepsy. I had brain acquired. My mother had herpes, so I got
Okay.
um, and my seizures have always been tied to menstruation. Um, and I never really had much menstruation. But at this point in life, I wonder if there's any natural things, or I, been on drugs my whole time. Started
Yeah.
phenobarbital at 10, but what else could I try? I really miss the estrogen.
Yeah. So you brought up so many great points, and it's such a great question. We know that during the menopause, the postmenopausal point in life, that there can be increased depression and there can be increased mood symptoms, and estrogen can help with so many things, but yet there's that risk of increased stroke with hormonal therapy. And so sometimes topical creams or topical estrogens can be helpful because you don't get that absorption into the blood. So that might be something to discuss with your doctor. And then certainly antidepressants or medications that help with anxiety can be very helpful, and talking to your doctor about interactions with seizure medications and those medications are important.
Um, I'm an old timer at this, so I'm really enjoying. I'm enjoying the conversation. Thank you for taking my question.
Oh, of course. Thank you for asking.
Thank you so much, Casey. Does anybody have any other questions as we go on? We will have more time to stop and ask questions too. So please know that this isn't the only time that we'll be asking questions.
Okay. So next, we're going to talk about hormonal contraceptives and anti-seizure medications. And it's really important when we think about what type of anti-seizure medication women are on, and is there an interaction with birth control? So when we think of anti-seizure medications, there are enzyme-inducing seizure medications like phenobarbital, phenytoin, but even oxcarbazepine, topiramate, and those medications do interact with estrogen. And so if a woman is taking one of those anti-seizure medications and is on an oral contraceptive medication, what happens is it actually lowers the efficacy of the birth control. So it lowers the estrogen in that oral contraceptive medication. And so usually what we recommend is either higher doses of being on an oral contraceptive medication, higher doses of estrogen within that oral contraceptive medication, or an IUD. And most neurologists, including myself, will really vote for an IUD because you don't really have to worry about those hormonal changes affecting the birth control and that risk of having an unintentional pregnancy. if there are medications that are non-enzyme inducing, and most of those are the newer medications, levetiracetam, lamotrigine, even Onfi is part of those non-enzyme inducing medications, and those don't have any effect on oral contraceptive medications. Regardless, we do recommend the IUD as being kind of the best way for contraception in terms of thinking about any hormonal changes that can happen. One thing that I just wanted to highlight about topiramate is one of those medications that's used for epilepsy and migraines in different doses. And so when we think of that interaction of topiramate with oral contraceptive medications, and particularly estrogen, it's usually at doses greater than 200 milligrams. And sometimes doses to treat migraines are lower. And so that risk isn't really there at lower doses. So something to keep in mind. The other thing I wanted to highlight is that lamotrigine is an anti-seizure medication that actually there's an interaction between lamotrigine and the oral contraceptive medication. So estrogen from a oral contraceptive medication increases the metabolism of lamotrigine. So it gets metabolized quicker, and it actually lowers the level of lamotrigine. So I've had patients that have come to me that are on lamotrigine, and if their OBGYN puts them on a oral contraceptive medication, it can lower the dose of lamotrigine. So we're always in constant communication to discuss, like, okay, we might need to increase the level or the dose of lamotrigine if depending on the birth control. So it's really important to know that there's lots of choices for contraception and epilepsy, and there's medication interactions. And so that's important to keep in mind. The general consensus is the IUD, and it's really important to talk about contraception with patients. And most patients, I find that unless I ask them, are you taking anything for birth control? If my nurse or my medical assistant is asking questions, that doesn't usually even come up as a medication. So it's really important to ask and to share that information, because it can really affect the seizures and medications. So when we think of preconception counseling and epilepsy as a whole, we know that that it's really important to have that open communication, to have enhancing folic acid use, which prevents against any major congenital malformations or major birth defects. We want to reduce seizure burden and really create an individualized approach. So when we think about pregnancy, intended or unintended, what do we do? What is our next step? So it's really about balance. We know that higher levels of anti-seizure medication, ASM is anti-seizure medications, increases the risk to the fetus. And we also know that lower levels of anti-seizure medication can increase the risk of seizures. So it really is about the balance. And my job is to talk to my patients and to discuss the balance about this. And it's really important with the developing baby and the mother, and the clinical decision-making is really important about balance. So what are the risks of seizures? We know that convulsive seizures can be dangerous if there's seizure-related falls, blunt trauma, injury to the developing baby with either lack of oxygen, or asphyxia where they are not getting oxygen or blood supply, that can be dangerous. And we also know that focal seizures, so seizures coming from one area of the brain that maybe don't have whole body shaking, can also cause some fetal distress. So our goal is really to be really proactive and to reduce the risk of seizures. And there are things that can be helpful to predict for seizures in pregnancy. So if there's a decrease in the levels of the medications, sometimes focal epilepsy can be actually harder to control. More than one medication can also potentially increase the risk of having seizures in pregnancy. And our best predictor is really on how women do 9 to 12 months before conception, so that 1 year before conception. And of course, there are exceptions to this rule. I just saw a patient in my office this past week, and she's of childbearing potential. And she started to experience these events of out of body, altered awareness. And all these seizures started 3 months postpartum, so 3 months after she delivered. And when we did an EEG, we discovered that the seizures were coming from the right temporal part of her brain. And she was treated with levetiracetam, and then she had some mood side effects, and she was transitioned to lamotrigine. And now, a year later, she's talking about getting pregnant again with her next child. And so we're doing all the things that we can do to predict for seizure freedom during pregnancy, but she is somebody who wasn't on seizure medications maybe a year before. So it is variable depending on the patient. And so this diagram talks about seizure frequency and anti-seizure levels in pregnancy and in pregnant women with epilepsy and non-pregnant women with epilepsy. So if you look at that, this first diagram here in A, and you look at the yellow graph here, when we look at the change in seizure frequency in pregnant women with epilepsy and non-pregnant women with epilepsy, there's really no change in seizure frequency. So that is that's really great information. And we know that the decrease in seizure frequency and the increase in seizure frequency, the blue and the red, is pretty similar in both groups. But when you look at the section in B here in diagram B, and we look at both of those green marks, there is definitely a change in the dose of the medication. So in pregnant women with epilepsy, we find that there is definitely an increase in the dose and a change compared to non-pregnant women with epilepsy. So the dosing does change dramatically, and non-pregnant women were more likely to not have a change in their dosing, and pregnant women were more likely to have a change. And so let's talk about why that is. Why do pregnant women why are we changing the anti-seizure medications during pregnancy? So during pregnancy, there are physiologic changes that happen in the body. There's increased blood volume. There can be swelling that happens, altered activity of the liver enzymes. And so what happens is there are some medications that actually are metabolized faster. And if you measure levels during pregnancy and non-pregnancy, you'll find that the levels of these medications can be lower. And so it's really these physiologic changes that happen during pregnancy that can lower our anti-seizure medications. And here's a diagram here at the bottom that shows you which medications are more likely to be affected than others. And lamotrigine is one of our favorite medications during pregnancy, and it is a medication that the levels during pregnancy really can be lowered as early as the 3rd week after contraception, but most hallmarked in the 3rd trimester. So really, what do? We check levels frequently during pregnancy and see, I usually see my patients every 4 to 6 weeks during pregnancy. So we're checking levels, checking in about how things are going, and making sure that we're really aiming for that pre-pregnancy level. And there's so much variability between patients. And so checking that level is really important. So what happened to our patient? 2 months later, she came in for follow-up, and she was pregnant. And she asked me all these questions. Are my seizures going to get worse? Will the medications or will the seizures hurt my baby, either structurally or cognitively? And what about breastfeeding? Can I breastfeed? And so these were great questions, and I was super excited that she shared with me that she was pregnant, and that I was also so grateful that we had the conversation beforehand about what to do, because I also think that I've heard so many stories from women that have not even shared with their doctor what they're thinking about for contraception and pregnancy. And so that open communication is really important. So when we talk about the risk of anti-seizure medications to the fetus or developing babies, there's really been so many studies that have been done across the world, and we're so lucky in our neurology realm that there's been so much cohesive data from Australia, North America, Europe, UK, Ireland, all these registries. And so when we talk about major congenital malformations, what are we really talking about? We're talking about cardiac abnormalities or neural tube defects, which basically means that the spine doesn't form correctly, maybe some cleft lip or cleft palate. So many different malformations here. And when we think about what is the prevalence of these major congenital malformations and these, if they picked 8 anti-seizure medications, this really gives us some good data to look to see what is the safest medications. And I think when you look at this chart, what you're looking at is 3 different studies. So the circle is the EREP study, the triangle is the North American study, and then the square is from UK and Ireland. And the most important thing I think in this is to really highlight that the studies were pretty similar across the world. And so what we found is that the most relevant studies that we found and the consistency of most of the studies is that levetiracetam or Keppra, lamotrigine or Lamictal, and oxcarbazepine have a lower risk compared to phenobarbital or valproic acid. And when we look to see, when we compare doses of lamotrigine compared to other anti-seizure medications, we say, okay, phenobarbital and valproic acid, those are, high risk. But what we also found is that the phenobarbital levels, like if you're taking a low dose of phenobarbital, that's pretty equivalent to being on lamotrigine at a moderate dose. So the dose can really play a role as well. And then the NEED trial was a trial really looking at neurodevelopmental effects of anti-seizure medication. So is a woman who takes anti-seizure medication, is there a risk of that, of a developing baby having any cognitive effects? And there was definitely a lower risk, again, similarly to what we found before with lamotrigine, levetiracetam, carbamazepine, phenytoin, topiramate compared to valproic acid and phenobarbital. So I think this is all really helpful information. It really helps to guide our treatment and really thinking about women of childbearing potential and putting them on safer medications right from the beginning rather than potentially waiting and making changes. Valproic acid, just a comment about that, it is effective for seizure control, and it can pose high risks to a fetus or developing baby, but it's also very important to think about the patient in front of you, the patient in front of me, and also to balance those risks of the women, and if that woman is thinking about pregnancy or not, and how that is affecting seizure control as well. And so this is really to emphasize that, yes, there's side effects of it. Valproic acid can cause congenital malformations. It can cause some other side effects. And it's really the dosing that plays an important role here. So what can we do to prevent major congenital malformations? So folic acid, preconceptual folic acid is recommended for all women of epilepsy of reproductive age. So it's really important. I put all my patients on folic acid, whether they are interested in becoming pregnant or not. And this is really because it can be very preventative and because most pregnancies are unplanned. The dose varies from 0.4 milligrams to 4 milligrams. And so there is still some studies going on to help figure out the dose. So 1 milligram to 4 milligrams is really what you'll see the most common. So I just wanted to highlight that we are talking about so many scary things about major congenital malformations and cognitive stuff and medications and seizures, but most women with epilepsy do have safe pregnancies. And I think this is, if you could take home anything from the talk today, it's actually this slide, because I will tell you that in my 15 years of practice, I've had so many young women, like early 20s, who come to me and say, I never knew I could get pregnant. I never knew that like that was okay for me. And it breaks my heart. And we do a lot of education. And if we need to get them off the Depakote that they are on, we make and we do it. And so just remember this, that most women with epilepsy have safe pregnancies and have normal developing children. So when we think about postpartum care and safety considerations, postpartum care really, a lot of the changes that we do with medications during pregnancy, the goal is to get the medication back to the pre-pregnancy state. So within that 1 to 3 weeks after delivery, there is a pretty quick titration back to a normal level or pre-pregnancy level. And that's because you can actually get toxic from having too much of that medication. And because those hormones have just changed as there's been a delivery. And so that medication adjustment, and that's where that communication with the neurologist and the OBGYN is really, really important. It's important after delivery to think about mood and to think about postpartum depression and anxiety, because that can definitely play a role. Breastfeeding is generally safe. And so I usually tell my patients early on that yes, breastfeeding is fine, and to communicate with the pediatrician and just let them know about the medications. And that there is a low transmission of breast milk through some of the medications. There is a low transmission of those, but some of those medications we use in babies when they have seizures, and so they are considered safe. So postpartum safety, sleep, stress, it's very important for a mom to have 6 to 8 hours of consolidated restful sleep, encouraging showers, avoiding baths. So any situation where you could have a breakthrough seizure is important to counsel, is important to talk about. I always talk to my patients about if you're alone with young children, what do you do? A smartwatch can be really helpful, actually. So it can alert a family member, it can alert 911, just safety-oriented behavior, changing a baby on a surface that's low to the ground, avoiding giving the baby a bath while alone, being careful of stairs, and avoiding co-sleeping. Okay, so this is when we talk about menopause and what happens in menopause in general, is that there already is this natural tendency for osteoporosis. And so women with epilepsy are at this heightened risk of developing osteoporosis due to some medications. And so that's something too that's really important to talk about and communicate about. And during menopause, there can be, just because those hormones are changing, there can be that change in seizure frequency as well. So in summary, it's really important to have this holistic care for women with epilepsy, and really important to have this comprehensive approach, because there's so many stages of life where hormones are changing, and then it's really that fluctuation of hormones that's crucial to discuss and can cause interaction with medications. And this is really, in the last few years, there's been some significant research that is going on, particularly during epilepsy and pregnancy, and how we can specifically address women's needs. And the goal is really that personalized individual approach, which is something that I love about epilepsy. Like, you cannot treat everybody exactly the same, and listening and discussion and that open communication is really important. So my goal is, when I see patients, is to first try to figure out, is this a focal epilepsy? Is it a generalized epilepsy? Where in the brain is this coming to? So even if I am seeing a patient who has had seizures for so many years, I still always go back to the drawing board. First, I need to know, like, what type of seizures are these? Why, is there any reason why they're happening? And then to optimize treatment for epilepsy, find the best medication, the lowest possible dose with the optimize treatment with the fewest side effects, and then talk about very early on contraceptive counseling, preconception counseling. What are your plans for pregnancy? What are you thinking about? And then I always think that it's important to check levels when I see patients. And that's, again, because most pregnancies are unplanned and we rely on that dose, that level during pregnancy. The importance of folic acid, and that EEGs can be really helpful as a diagnostic test. And so here's an example of an EEG. I do in-office EEGs, and I also do home EEGs where patients come in, they get hooked up, they take all the electrodes home, and we can monitor patients at home in the comfort of their own home. And it gives us really good information about what's happening at home, what are those seizures like, and then there's video with those as well. So this is my practice. I'm located in East Providence, Rhode Island, and I have been in academics, and then I was in a group practice for several years, and now I just launched my own practice this summer, and I felt like there was such a need for seizures and epilepsy, and so my practice is really focused on seizures and epilepsy, and I am here to help, and if you need anything and you want to reach out, please let me know. And I'm happy to take any questions.
Awesome. Thank you so much, Dr. Gupta. So we do have a lot of questions coming in.
Great.
Jennifer White, she kind of had one right after Casey had gone. Jennifer, if you want to unmute yourself and ask your question, go for it.
Okay, so my question is, I'm going to be getting a hysterectomy this month or this year. I don't know when, but the process has been, I finally found a doctor willing to do it.
Great.
And actually it's only partially because of concerns of epilepsy. Because okay, I got epilepsy when I was 13.
Mm-hmm.
And so right around the time when teenagers go into puberty, and I've always had extremely heavy periods, and I've been taking the Depo-Provera and anything else that would work it isn't up for consideration, not even the IUD. So hence the hysterectomy. So I just want to know what to expect and how many doctors am I going to be dealing with?
I know. Great question. Great question. So what to expect in terms of seizures and changes after hysterectomy? And it really depends if, as part of the hysterectomy, sometimes the ovaries are removed as well. Sometimes both ovaries, sometimes one ovary, sometimes the ovaries stay. And so that really can play a role on the hormones and how one feels afterwards. So if the ovaries are staying, then they will continue to produce estrogen and progesterone as they would throughout a typically developmental cycle of a woman, but you wouldn't get your menstrual cycle. So you would still get those estrogen and progesterone changes, but you just wouldn't get your menstrual cycle because there's no uterus there.
Yeah, it's just my concern is I'd like to get a full one to get the ovaries removed as well. My doctor seemed less likely to agree to that, and I know I'm probably facing an uphill battle with the surgeon's unit as well.
Yeah, so I think that if you get your ovaries removed, if there's a hysterectomy and the ovaries are removed as well, most women experience like kind of that abrupt onset of menopause. So you can get the hot, there's like the menopause symptoms, the hot flashes, sometimes mood changes. But from a seizure standpoint, it can be variable because now there's not estrogen and progesterone, and sometimes women get put on hormone replacement, and that can help sometimes to control seizures. And so it can be pretty variable. And then it'll also depend on the medication regimen that you're on for seizures and if there's any effects of the hormones from that as well.
Okay, because I still have I have both epileptic and non-epileptic seizures,
Okay.
and I'm about to go on to my third seizure medication.
Okay.
Um, and I'm not sure if my doctor wasn't available to meet, so I met with her nurse,
Yeah.
and it wasn't entire like I haven't gotten the prescription yet, and it wasn't entirely clear if I'm going to be going on it slowly to um get off of Keppra, or if it's going to be another addition.
Okay. Yeah, I think that communicating with your neurologist about the surgery, the procedure, asking those questions, how am I going to feel after? Does the medication interact with hormones, or is it not going to have an effect, the medications itself? And then what is that likelihood of having seizures afterwards? Can be really helpful.
Okay.
So thank you so much, Jen, for asking such an important question.
Thank you.
We also have some other questions that we have kind of coming through. There was a question about, Isabella asked the question, has there been studies on Fintepla and Epidiolex and Onfi? And I'm guessing, Isabella, are you asking about during pregnancy?
Okay, go ahead.
Yes, I am.
Okay, I just want to make sure I was asking your question correctly.
Great, so that's a great question. And Epidiolex is a medication that has, right now, it's approved for pediatric epilepsy, particularly Dravet syndrome or Lennox-Gastaut. And I've had some patients in the adult world who have tried so many different medications, and it's a battle to get it approved. Sometimes I've had some patients where I've been lucky and I've got it approved, and it's like they're, a third or fourth anti-seizure medication. And so it's hard in the adult world to get Epidiolex, and I hope that that changes at some point in the future. And we know that there is an interaction between Epidiolex and clobazam or Onfi, that if those two are taken together, or any cannabidiol or cannabinoids with Onfi, that it causes prolonged Onfi, or those levels are increased in the serum. And so as of now, I don't know if as far as I know, there hasn't been any studies, but I think Epidiolex, that would be a great study to do during pregnancy, and it would actually be fascinating to see how it compares to our medication regimen.
Yeah, Epidiolex is my medication, and Fintepla and Onfi, and also lorazepam
Yeah.
for rescue.
Okay. Yeah. And we know that during pregnancy, lorazepam is okay to take. Like, it can have some side effects, but if it's a seizure rescue, we know that it's definitely better than having the seizure. So that is still recommended. And I definitely give Klonopin or lorazepam to my patients as a seizure rescue, in addition to medications like Valtoco or medications that you can use through an intranasal formulation. Great question.
What about Fintepla?
I don't know of any studies with that as of yet. But you're bringing up great points and great studies that need to get done.
Yes, and I believe there's a link to the registry that I can go ahead and I'll look up and I'll put it in the chat so that people can actually look it for themselves and see the registry, which is kind of interesting.
Thank you.
You're welcome. We also have another quick question too about menopause. Questions about menopause, when it starts, and then the hormones during menopause and treatment, and how that could possibly change seizure patterns.
Great question. So menopause, perimenopause, it is so variable. And I think that I wish that we could say, okay, we could predict when menopause is going to start, how long the perimenopausal symptoms are going to last, and help to really guide our approach. I think that the best that we have right now is really keeping a diary and keeping a log and logging those symptoms and discussion about kind of what's happening to help predict what those changes in estrogen and progesterone are. Sometimes we can check blood levels, but they're so variable that it's not routinely checked. We definitely know that because estrogen is considered a pro-convulsant, so can trigger seizures, and progesterone is considered an anti-convulsant, so potentially less likely to have seizures when there's increased level of progesterone. During menopause, when those estrogen levels are coming down, we typically expect that the seizures will improve. So similarly, actually, to migraines, we find that a lot of women get migraines around their menstrual cycle, and as the cycles and as that estrogen reduces, sometimes the headaches just they go away. So also being in that constant communication with your doctor about how you're feeling and what are symptoms that you're getting of premenopause and menopause and postmenopause are really important.
Wonderful. Sarah, you have your hand up. Go ahead, Sarah.
So I'm on the depot shot and I'm getting almost close to that age, but we not sure like when to start me. I had talked to my neurologist and primary about it. The bug their ear about it, both of them. But we don't know how it's going to change and how it's going to affect. Because when I was a kid, younger, I would had seizures during all my periods.
Okay.
So I wasn't sure like when to have them start looking into everything.
And you're talking about menopause, Sarah?
Yes.
Okay.
Talking about menopause and coming off of the Depo-Provera?
Yeah, they want me to possibly come off soon.
Yeah, I think that that's a tough question, right? Like, how do you've been on the Depo-Provera for so long, and now what's
15 years.
15 years, yeah. And thinking about coming off of that, and actually, I think the question is, what is your body doing in terms of the estrogen and progesterone that your body is producing? And do you still need that or not? So I don't have a good answer for that. And I think it would really be about, sometimes it is a little bit of, okay, let's try it. Let's reduce your dose. Let's see what happens. But let's meet frequently to talk about how you're doing, so that if we need to make the change, we are talking about it and communicating.
Thank you so much, Dr. Gupta. Carrie. And Carrie, for our time, Carrie's going to be our last question for tonight. But I do want to just remind everybody that if you haven't yet, on April 12th, yes, we are going to be having our annual women's conference, and Dr. Gupta will be speaking at our women's conference. So if you have not had information about that, I'll also put that in the chat and email you guys after tonight's webinar about the women's conference coming up on April 12th. So we hope everybody that's here tonight on the call is able to come to women's conference. So go ahead, Carrie.
Well, I'm 52. I've had epilepsy since I was 2, so it's been a while. And now I'm at the point where I am postmenopausal. But more recently, the Tegretol that I've been taking had started to reduce my sodium level to very dangerous levels. And hospitalized as a result of that. And then of course taken off the Tegretol. And so now I'm in the middle of a med change. And one of the things that I guess I have a question about is, when it comes to the use of hormones in treatment, to be able to, I've been on a lot of different seizure meds over the years. More recently, they put me on Onfi, but I think that, and I'm still having breakthrough seizures. So, they're going to be adding a new medication, cenobamate, a new medication to it. But ultimately, I guess I'm just curious about if, hormone treatment is utilized because of the protective factors with the progesterone, and because things are, does it help to stabilize the hormones and such in that postmenopausal state as a part of the treatment?
That's a great question. And it is definitely hard to make a change off of medication that you've been on for so long. And sometimes, yes, if you get that dangerously low sodium, it has to be done quick because the side effects are, they're so severe. But coming off a medication like carbamazepine or Tegretol that has some mood effect to it, I've found with a lot of patients that if we have to come off a medication like carbamazepine or Tegretol, that sometimes it's treating some mood symptoms. And when we make a change, there can also be some mood symptoms that come out. So just being aware of that is really important, along with, the risk of osteoporosis from being on a medication long-term from that. So there are some benefits, but there's also some other things that might come up when you're tapered off a medication rather quickly for reasons that you need to be. And so that's a great question. Can hormones be helpful as like a preventative measure? We typically don't use like progesterone as an anti-seizure medication. And I think we really rely on like the body's endogenous production of those hormones to either be like a proconvulsant or an anticonvulsant. But I think, I love that thought, but I think that, I don't know, we're not there yet. And I wonder if there's long-term side effects of just using like progesterone as an anti-seizure medication in and of itself. But I really wonder, if there's been any mood changes, if you've noticed, because that's another thing too that comes up with menopause, that a lot of women will talk about mood changes, depression, having mood swings, with that back and forth. And so I know I don't have a good answer for you, but I just, want to open that discussion because I think there could be multiple things going on.
I think that the major part of the process for me anyway has been that coming off, I titrated very slowly off the Tegretol, but ultimately the transition onto the Onfi. Tegretol was the only medication that's ever kept me with seizure free. I was on it for 35 years.
Oh, wow.
So, there was concern, and I requested a bone density test to be able to sort of see. There was a small amount of osteopenia in, I think, one of my hips, but so it's not something I can continue to take. But at this point, I feel like there's some of the other stuff, being put on controlled substance after controlled substance
Yeah.
after controlled substance. it just doesn't seem like a really good solution in terms of mental health. I'm a clinician, so mental health,
Yeah.
or in terms of, you know, just the practical side of, you know, being able to function in a regular everyday life.
Thank you so much, Carrie, for sharing your question. I am going to close for questions, and I'm sorry, I know there's so many great ones. But like I was saying before, on April 12th at the Hyatt in Cambridge, Massachusetts, the events should be getting up on our website this week, so we'll make sure that we send you guys the link. But you would have a chance to actually meet Dr. Gupta in person. She will be speaking at our conference with a host of other wonderful women physicians, neurologists that will be there talking. We'll also have pampering in the beginning, so massages, jewelry making, journal making, and then some brunch, some food. We're going to fill you up. And then we'll have these great conversations that we're having now. And you'll have a chance to ask more questions and just be there with other women. So it's all women, but we do welcome family members to come too. So, I mean, if you are looking at getting pregnant, your spouse or your partner wants to come with you, then more than welcome to have them come along as well. So please know that this is for all family as well, even though the target audience is definitely women. So, but we are so happy to have all of you with us tonight. And again, thank you so much, Dr. Gupta, for volunteering your time to spend with all of us tonight. We're so lucky to have you. This is recorded, so we will be sending out the recording, and so grateful to have you here with us tonight.
Thank you so much, Christine and Amy, for inviting me, and for all of you for your wonderful questions and creating a great conversation. So thank you so much, and I look forward to seeing all of you soon.
Wonderful. Have a great night, everybody.
Thank you.